Good afternoon, everyone. I'm Dr. Madhura Gavane, Consultant Radiologist at Vijaya Diagnostic Center, and I welcome you all to today's session of Vijaya Diagnostic Center's Diagnostic Education webinar series. And topic for today's session is minor markers in pregnancy, also known as the soft markers. Now, these minor markers, as such, are not gross abnormalities, but are indicative of an increased risk of an underlying fetal aneuploidy or some non-chromosomal abnormality. And thus, these minor markers become major concerns for the doctors and the patients. And our speaker today will be talking about it in detail. And for the clinical perspective, we have with us a very senior and eminent gynecologist, Padma Shri Dr. Manjula Anagani, ma'am. It is my pleasure and privilege to welcome you, ma'am, as our chief guest for today's webinar. Ma'am honestly doesn't need any introduction. Ma'am's name is synonymous with laparoscopic surgeries. But as a protocol, I'm going to go forward and formally introduce ma'am. So Dr. Manjula Anagani ma'am is presently the clinical director and head of the Department of Obstetrics and Gynecology at Care Hospital and a visiting laparoscopic surgeon at NMC Hospitals, Dubai, and an honorary associate professor at NTR University. She did her MD obstetrics and gynecology from Usmania Medical College, following which she has underwent training in prenatal genetic evaluation, infertility, ultrasonography, and minimally invasive procedures. She pioneered the art of laparoscopy in the late 90s when lap was only an emerging technology then. Her achievements include working on the ergonomics of laparoscopy for women and evolving newer techniques
I
in
heard
laparoscopy and minimally invasive surgery.
Madhura will continue with this topic.
I've tried to keep it very minimal, ma'am. So, ma'am's work is mostly recognized for her work on primary amenorrhea for using the autologous stem cells for endometrium regeneration and new techniques of creating neovagina in minimally invasive surgery with more than 30 years of experience in the clinical and teaching field. And she's also Guinness World Record holder for removing maximum number of fibroids in a single patient and was awarded the Distinguished Padma Shri in the year 2015 and many more healthcare excellence awards and many more best paper awards for Foxy. And ma'am has co-founded the NGO Pratyusha Support and also the campaign Suyosha, a perfect woman. So we are indeed honored, ma'am, to have you at this webinar to share your thoughts, and I once again extend my warm welcome to you. And our
Thank
speaker today, Dr. Deepthi, who is a graduate of Kakatiya Medical College, following which she did her diploma from JNMC Belgaum and has been associated with Vijaya Diagnostic for past 6 years. So first, I would request Manjula ma'am to give her clinical perspective on today's topic of minor markers.
Thank you, Dr. Madhura, for a wonderful introduction and all the best. And thank you, Vijaya Diagnostics, for making me today's guest because this is a topic where, when something is very obvious, it is very obvious for all of us to make decisions and make it very easy for us to tell the patient and their attendants, yes, this is wrong. So we have to go ahead with it. But when it comes to minor markers or soft markers, we have four things which we think of. First, the patient and patient trust and confidence is on us, and we are not able to see anything through the eyes. Means we have to believe on the ultrasonologist because our eyes cannot see what is happening to the baby. So we are dependent on ultrasonologists. And we do know it is subjective and inter-observer variation is there for minor markers. That's where we are in the dilemma where whom to send to, where to send. And the third point is that when to terminate. The whole thing comes into that, do we have to terminate? And is it below 20 weeks that we are ready to terminate or not? So, like Dr. Madhura said, it is for the structural plus genetic, non-structural plus genetic, both the things which we look at. And we do know there are what are the other available tests available? Biochemical markers, which Dr. Deepthi will be talking about. But the sensitivities of it and the correlation with the ultrasonography will go a long way, not just depending on one thing. And I also look at, there are certain soft markers which are well seen in the first trimester, better seen in third trimester, where we cannot make any decisions. So can we do something much more better below 20 weeks, even though the government has given in the MTP Act till 24 weeks, we would try to do the termination is much more easier if it is less than 20 weeks. So the correlation and if at all the decision has to be taken by us, then when to send for MRI and all these things are things which we expect as a clinician. So I think the clarity, the vision, what we have to see, which we cannot through the skin of the patient, Deepthi is going to give it to us. All the best, Deepthi. Way to go.
Thank you, ma'am. Thank you, ma'am.
Thank you, ma'am.
Good evening, one and all. Today we will be discussing about the minor markers in pregnancy. However, they are not minor anymore as they have gained quite a lot of weightage from the last 2 decades in detecting chromosomal anomalies along with few biochemical markers. It's their accessibility, non-invasiveness, and accuracy makes them important compared to their invasive counterparts like amniocentesis and chorionic villus sampling. Not only at risk population, but they have become a routine in pregnancy screening in everybody, as everybody wants a healthy baby. Now, coming to the risk group, maternal age comes first, then coming as a previous baby with neural tube defects, any family history, and
Excuse me.
consanguinity.
We are not seeing any slides. Can you not?
Yes, yes, ma'am. Yes, yes. Yeah. Now, coming to their significance, these soft markers with little or no pathological significance are found in aneuploidy fetuses as well as normal fetuses. When isolatedly found, they might not have any clinical significance. However, associations between some and adverse pregnancies have been found, which include intrauterine death, preterm birth, intrauterine growth retardation, and congenital infections. In past several decades, ultrasound screening in pregnancy for fetal anomalies has developed remarkably, which include extensive screening for minor markers. These include fetal ventriculomegaly, choroid plexus cyst, hypoplastic or absent nasal bone, nuchal fold thickness, intracardiac ecogenic focus, ecogenic bowel, short long bones, pylectasis, and single umbilical artery. So we will be seeing everything in detail. And usually the chromosomal anomalies that we expect from these are trisomy 21, which is Downs, trisomy 18, which is Edwards, trisomy 13, which is Patau, Turner's, and then triploidy. Use of soft markers may increase the positive predictive value in patients with first trimester combined screening. A combination of maternal age and biochemical screening tests such as beta HCG and PAPA and NT, which is what we call the double marker screening. NIPT is also used for screening trisomy potentially for some sex chromosomal aneuploidies and microdeletions. However, fetuses with structural abnormalities should be offered diagnostic testing with chromosomal microarrays. Most of the anomalous fetuses have single soft marker in at least 95% fetuses, 2 in at least 4% fetuses, and 3 or more in at least 1% fetuses. Consider coming to ventriculomegaly. Consider dilated if the atrium of the lateral ventricle is 10 mm or more. And the grading is like 10 to 12 mm is mild, 12 to 15 mm is moderate, and greater than 15 mm is severe. Ventriculomegaly has been associated, it could be normal, it could be aneuploidy fetuses, genetic syndromes, primary brain abnormalities, congenital infections, cerebrovascular accidents, and in intracranial hemorrhage. And this is what is ventriculomegaly. And this is the normal atrium of the ventricle, and this is the dilated atrium of the cerebrolateral ventricle. And this is where we are supposed to measure the diameter of the atrium. A presence of neurodevelopmental delay in cases of apparently isolated unilateral mild or moderate ventriculomegaly cases. High rates of cerebral palsy, seizures, and impaired motor capabilities were observed in severe ventriculomegaly cases. Overall prognosis depends on any associated abnormalities. Now, coming to choroid plexus cyst. It is a small sonographically discrete fluid-filled space of greater than 5 mm within the choroid plexus. It is seen as a black echo-free area, and it should be at least 2.5 mm before 22 weeks and at least 2 mm after 22 weeks. It is found usually between 16 to 24 weeks gestation as an isolated finding or in association with any other chromosomal anomalies. Women with associated CPC and negative first trimester screening and NIPT, then it's considered as normal variant or clinically insignificant. Fetuses with trisomies have choroid plexus cyst greater than 10 mm. And this is where we get the, this is a normal choroid plexus on both sides, and these are the ventricles. And this is where we find the choroid plexus cyst, and this is how it looks. And coming to absent or hypoplastic nasal bone. Nasal bone is not visible in first trimester or is less than 2.5 mm in second trimester. Usually, according to ethnicity, Koreans have a small nasal bone compared to Caucasians. During first trimester screening for Downs, maternal age and fetal nuchal translucency detects about 70%. However, absence of nasal bone increase the chances by 80%. Other scenarios where there is absent nasal bone seen in such as It is in basal immunodeficiency, Cry-du-Chat syndrome, and partial trisomy. And this is where we are supposed to measure the nasal bone. And this is the heart pellet. This is where we have to measure the nasal bone. This is a normal fetus, and in this fetus we don't have any nasal bone here. And next, coming to nuchal fold thickness. It's defined as thickening of the skin and subcutaneous tissues on the posterior aspect of fetal neck, measuring 6 mm or greater before 20 weeks 6 days. Thickened nuchal fold in second trimester has more significance for downs rather than first. Hence, karyotyping is offered in fetuses with thickened nuchal fold. Recent data indicates a positive association between thickened nuchal fold and congenital heart defects. And this is the transcerebellar diameter. Usually, they say that before third trimester, transcerebellar diameter correlates with the gestational weeks. And this is where we are supposed to measure the nuchal fold thickness, as well as this is where we measure the cisterna magna as well. And coming to the nuchal translucency, screening NT could detect about 80% of fetuses with trisomy 21. NT plus double marker, that is beta HCG plus free papa, detects about 90%. However, NT, double marker, nasal bone, and ductus venous flow. If we include all four, then we have detection rates by 95%. Protocol according to Fetal Medicine Foundation is that is how to measure NT and when to measure NT. It is usually done between 11 weeks and 13 weeks, 6 days. The CRL should be at least 45 to 84 mm, and it should be in neutral position with head in line with the spine. They should be able to differentiate between skin and amnion. Mid sagittal view should be used, which includes tip of the nose, rectangular palate, and diencephalon in the center. And this is the correct way of measuring NT. This is the nasal bone, heart pellet, diencephalon, and this is where we are supposed to measure the NT. In this fetus, it shows there is thickened NT. And triple marker is which includes maternal serum AFP, free estriol, and beta HCG, which is done between 15 to 21 weeks. Quadruple marker is triple marker plus dimeric inhibin A, which is done usually between 15 to 22 weeks. And recently we are getting the pentamarker test, in which include maternal serum AFP, beta HCG, unconjugated estriol, dimeric inhibin A, and glycosylated HCG, which is done usually between 11 weeks and 13 weeks, 6 days. Coming to intracardiac ecogenic focus. It is defined as ecogenic spot inside the heart with brightness equivalent to that of a bone. 88% are seen in left ventricle and 5% are seen in right ventricle. It is found usually in 3 to 5% of normal fetuses and 25% in trisomies. In 90% fetuses, they resolve usually by third trimester, and it is less than 3 mm. In cases of isolated intracardiac ecogenic focus, there is no evidence of any altered cardiac function, or detailed echo is not needed unless until other anomaly is associated. And this is how the ecogenic focus looks. Here there are two ecogenic foci within the left ventricle, and this is a normal formation of the heart. And coming to ecogenic bowel, defined as fetal bowel with similar or greater ecogenicity than bone, it resolves spontaneously in 19.7% fetuses, and it can be associated with the cytomegalovirus infection, aneuploidy, intraamniotic bleeding, severe uteroplacental insufficiency, meconium peritonitis, cystic fibrosis, anemia, and fetal IUGR. And grading of ecogenic bowel is done according to the ecogenicity of the liver or bone. Grade 0 is isoechoic to liver. 1, it's mildly hyperechoic to liver. Grade 2, moderately to hyperechoic to liver and ecogenic to bone. And grade 3 is markedly hyperechoic to liver and greater than bone. Serial growth assessments are required, as it is also with growth associated with growth restrictions. Ecogenic bowel in third trimester likely increases the postnatal surgical intervention for fetal anomalies is significantly increased. And this is how we compare the ecogenic bowel. This is the normal bowel, this is the liver, and this is the ecogenic bowel, which is compared to the ecogenicity of the bone. This is the vertebral body, and this is the ecogenic bowel. This is how we are supposed to compare. And shortened humerus and femur. Defined as bone length below 5th percentile of gestational age. Short long bones are associated with aneuploidy, structure abnormalities, skeletal dysplasias, preeclampsia, intrauterine death, IUGR, and oligohydramnios. And this is a case of short long bones, all humerus, femur, all the long bones are shortened, including tibia and femur. An isolated short FL was associated with small for age infants. Short HL and FL may be an early sign of placental dysfunction and increase in the warrant of antenatal surveillance to rule out IUGR and also requires frequent blood pressure monitoring. Femur is compared to all long bones. Severe limb reductions, as in thanatophoric dwarfism, can be detected from 16 weeks. Achondroplasia is usually detected from greater than 22 weeks. Coming to fetal pylectasis, defined as anterior-posterior measurement in a transverse scanning plane of 4 mm or larger in second trimester and 7 mm or larger in third trimester, whereas diameter greater than 10 mm is considered as hydronephrosis. Majority of cases, pylectasis detected in second trimester will resolve either before delivery or within the first year postnatal life. In prenatal renal pelvis, diameter of greater than 7 mm at 30 weeks, then postnatal follow-up is suggested. According to fetal urology census, AP diameter of greater than 4 mm up to 28 weeks and greater than 7 mm after 28 weeks. And it could be due to PUJ obstruction, vesico-ureteric junction obstruction, post-urethral valves, and vesico-ureteric reflux and duplex kidney. And this is how we are supposed to measure the AP diameter of renal pelvis in an axial plane. This is a dilated pelvis and this is a normal kidney. And coming to single umbilical artery, absence of one umbilical artery is considered uh, associated finding in 60 to 80% cases. 70% chances that left umbilical artery is absent. Some studies have shown a higher risk for preterm birth, PIH, and admission into the ICU. And this is how we are supposed to see the umbilical artery. They say it's a Mickey Mouse sign because they have 2 ears here. Here we have only 1 ear, and this is one vein and 2 arteries. And there are the rare minor markers. Rare but more specific minor markers include sandal gap, clinodactyly, middle phalanx hypoplasia of fifth finger. Sandal gap is a gap between great toe and the rest of the toes, and it can be associated. It could be normal or it's an isolated finding. It's also seen in Down syndrome and Clough syndrome. Could be due to amniotic band, or could be a part of ectrodactyly, which includes split hand and split foot deformity. And this is how the sandal gap looks. And in utero, it's how we can see it. And clinodactyly is radial angulation at an interphalangeal joint in the radioulnar or palmar planes, typically in fifth finger, sometimes absent middle phalanx of fifth finger, also seen in trisomies. And this is a hypoplasia of middle phalanx of fifth digit, also seen in Downs. Soft markers of undefined association, which are clenched foot, rocker bottom foot that is prominent calcaneus, and strawberry shaped skull associated with Edwards syndrome. Antenatal ultrasound shows brachycephaly with increased cephalic index. Biparital diameter to fronto-occipital diameter approaches 95th percentile. Flattened occiput due to hypoplasia of occipital bones, and pointed frontal bones due to hypoplasia of frontal lobes of brain. And these are the clenched fits, and this is a normal foot with normal angle, and this is a rocker bottom foot with prominent calcaneum, and this is a club foot, and this is an MRI picture of the same. This is a normal foot with normal angle, this is a rocker bottom foot, and this is a club foot. And these are the anomalies we find in a Down's fetus. We can have increased nuchal thickening, we have mild ventricular dilatation, brachycephaly, hypoplastic nose, clinodactyly, ecogenic bowel, sandal gap, short long bones, widened pelvis, pylectasis, and ecogenic intracardiac focus. Basically, all the minor markers could be seen in Down syndrome fetus. And a diagnosis of Down syndrome can be done by chorionic villus sampling, percutaneous umbilical blood sampling, which is done usually after 18th week, and extraction of fetal cells from maternal circulation. Coming to a new topic, prenasal thickness, shortest distance between the anterior edge of the lowest part of frontal bone and the facial skin anteriorly. Studies have been done to evaluate the feasibility of incorporating two-dimensional ultrasound measurements of nasal bone length and prenasal thickness into a second trimester anomaly scan, and to determine whether the nasal bone length to prenasal thickness ratio could help in differentiating euploid and Down syndrome fetuses. Usually done between 14 to 28 weeks. The mean nasal bone length to prenasal thickness ratio showed a gradual increase from 1.48 to 1.79 between 14 to 28 weeks. And this is how we measure the prenasal thickness. And this is the nasal bone, which is hypoplastic in this fetus, and this is the normal fetus. And this is a small uh, graph where we are seeing all the gestational weeks along with prenasal thickness and nasal bone length and the ratio. If the ratio is exceeding compared to this table, then I guess it's a abnormal finding. And there ends my presentation. Thank you.
Thank you, Dr. Deepthi ma'am, for your comprehensive talk. Over
Can
to
I add?
Manjula ma'am for your comments, ma'am.
Yes. No, I just wanted to add one thing. Pentamarker does not include glycosylate HCG. One HCG is enough. What we add is PLGF. What is PLGF? PLGF is a placental growth factor. The reason pentamarker has come is to detect the, we used to do, if you all remember, uterine artery Dopplers at 16 to 18 weeks, which we no longer do. We don't ask. But now when we want PLGF, we ask. So when we ask as a clinician, the first trimester scan, when I send it at 11 to 13 weeks, as a rule, we want you, please remember, we want you to do NT, cervical length, irrespective of whether we ask or not, and bilateral uterine artery Dopplers. The
Oh,
reason behind it is we correlate this with pentamarkers. Pentamarker include the regular AFP, inhibin, the PAPA, and the HCG with PLGF, where we correlate the chance of a mother getting the PRH later on.
okay.
So the NT and the uterine artery Dopplers are included from your scan for us to calculate the things later. Cervical length, you know why it is important to us. So
Yes, yes.
that's why it's very, very important for us, because
Okay.
no longer we are like you all went on from small things to now making soft markers very important for us. The double marker, then triple marker, quadruple marker. Now we are concentrating on pentamarkers because that will help us in that. Second thing I wanted to ask all of you, because everywhere we know that single soft marker we can ignore, that is what everybody says. Now if it is a double marker, it is two soft markers, yes, it is significant, again depending on what they are. And if something is missed, that's when the problem comes for us. It has been a personal experience where something like rock bottom, like you said, your club foot, if it is not detected before 25, 26, by whatever chance, and a ecogenic bubble, which is really, really not very easy to detect before the second trimester, that's when the problem comes for us, because at 26, 28 weeks, the patient attendant comes and really tells that you got all the scans done, you did it, and then you did not tell us. So how do you think we, all of us together, should be dealing with it?
There should be a protocol, ma'am, proper protocol, because every center and every radiologist has their own protocol. In a few people, they take the measurement first and then see the fetus. Few people, they do it as they are following the scan. But usually what I follow is we have to see the angles of both feet and both hands, and we have to see whether the fingers are properly spread. If it's not comfortable, you ask the patient to come again, and then I guess we could screen it twice or thrice while taking measurements, and screening for exclusively the minor markers once. It takes a little time, but time and patience, and experience as well.
Yeah. So I think the eyes, the pattern, I think for me,
Yes, ma'am.
laparoscopy or anything, when we go inside and see, if the pattern is not fitting into what I see in my brain, there is
Yes.
something wrong. I think the development of that holds true for you guys also.
Yes,
So
ma'am. Yes, yes.
it was very, very good and comprehensive. I was just thinking all the nine things the way you told. I was reading an article in 2005 which was talking about the same things then and the same things now, the same thing. But yes, we did come a long way in detection. And now the next point I wanted to ask you is MRI. A
Yes,
good
yes.
PIFA scan plus MRI versus MRI.
Uh, Ma'am, usually we don't suggest MRI for every fetus because unless until we are sure that something is there and we can't detect on ultrasound, then only we suggest to go for an MRI. And few people are insisting because they are consanguineous, can we get an MRI done? Is it 100% confirmative? For their assurance, we are referring them. Otherwise, we usually, if we are not comfortable with the fetus, if the liquor is low, if we can't get the position properly, then only we are suggesting for MRI. Otherwise, it's an expensive test, ma'am. Around 15,000.
Yeah.
Most of them are not affordable.
Yeah.
So,
I know, because the whole thing comes down again to, like I said, the termination and the decision making by the patient and by us about the terminations. That is where this whole and the MTP Act and everything
yes,
comes up.
yes, yes.
And when we do all this again, the thing of PCP and DT also starts coming on our head. That's when the soft markers and the detections and everything starts coming. Yeah. So anything you thought in the last 2 decades which has evolved better, like one in your presentation, I did see from what I did not see that time to this is, yeah, fetal nose and everything is fine, but that the gap between the fetal nose, the nasal bridge, and the thing was something which is new, which you guys have
Yes,
been
yes.
starting. So you think that did make a huge difference in detection of Down syndrome?
Um, Down syndrome, I guess only presence of one or two might indicate Downs, ma'am. But if only nasal bone is hypoplastic, then I guess we have to see. If only one minor marker is there, then I guess we have to evaluate for everything. Anosmia, hypoplastic nose, and the prenasal thickness. Rest all we have to screen one by one. If one is there, we have to screen for everything. If
Be-
everything is normal, then I guess that only
because
prenasal thickness increase. I don't think so. It's that significant.
because we did have one patient where everything NT was normal, everything was normal, everywhere it was only nasal bone absent.
Absent,
Now
absent.
it was a big dilemma for us. We also suggested for them to go in for amniocentesis. Um, she did not go for amnio because actually most of the patients want to avoid. She did go for like I was talking to you the other day. I don't believe in NIPT, but she did go for it. Again, it says 99%. So we were waiting till the last because we did not go for termination. The baby turned out to be absolutely normal. But again, if God forbid, if something was wrong,
Strong.
that's when the problem whole thing comes in, because throughout the skin, including the third trimester scan, they said nasal bone not ossified, nasal bone not visualized. So the difference I wanted to know is ossified, not visualized. Do you think there's a difference in that?
Or not ossified is, I guess they have to say it's hypoplastic, ma'am. Absent
Mm.
is absent completely. I guess non-ossified is a little hypoplastic rather than not visualized. Both are different.
Okay. I think this actually gets me to my questions and my doubts, definitely. Thank you, Deepthi. And but I only hope that really the radiologist has that 30-minute time to actually take time to do the TIFA scans and give, because I have seen scans, pardon me, with one absent hand being given normal, absent limb being given normal, baby comes out with absent limbs and all that also. So I hope that does not happen with any other dermatologist.
So there are no questions on the chat board as of now. So I think we can conclude today's session. So thank you so much once again, ma'am, for taking the time out to be with us on this webinar. Thank you so much. And
Thank
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 you.
you to all the attendees. I hope it was very insightful and informative for them. And also would like to thank the technical team and the management at Vijaya Diagnostic. And last but not the least, Dr. Kishore Reddy, the Director of Radiology. He's been constantly very supportive and encouraging to all of us. Thank you. Thank
Thank
you
you,
so
Kishore
much.
sir.
Thank you, ma'am. Thank you.
Thank you. Bye.